Good evening. This is Dr. Shaista, Senior Registrar, Yashoda Hospital, Malakpet, Emergency Medicine. Welcome to today's webinar. Today we have Dr. Ranjit C.H., Consultant Emergency Medicine from Yashoda Hospital, Samajgura, as a speaker for the day. He will be enlightening us with the topic Approach to Syncope in ER. Over to you, Dr. Ranjit.
Good morning, everybody. Thank you, Saishta, for the kind introduction. So, myself, Dr. Ranjit, I'm currently working as an emergency consultant in Yashoda Hospital, and I've got more than 7 years of experience in the emergency. So, today we'll be talking about syncope in the emergency department, which is one of the most common presentations. I felt the need for this to be the topic of discussion because most of the times we see it, but we fail to diagnose it properly because nearly 20% of the cases presenting to the department with syncope are we won't be able to find out the etiology. So, and it will be usually difficult for us to differentiate it with other things. There are some syncope mimics, so which we'll be discussing shortly. So, and I felt there should be a systematic examination and a history taking, which will help us in guiding us to delineate what could be the ideal cause of, or what is the cause of syncope, and how it can mimic, or how to differentiate it from other causes. So my objectives would be these things. So we'll be discussing about the definition, how to differentiate with the seizure, which is the most other common presenting, or which is the main differential for syncope. And once we diagnose it as a syncope, then how do we differentiate it from cardiac or non-cardiac syncope? And are there any decision-making rules or clinical gestalt which will help us in risk stratifying the patient, whether to admit or to discharge, or any further follow-up is required? So then is there any routine blood workup done, or imaging necessary? And what is the role of POCUS in syncope? Then is it necessary to do a workup for P for a patient presenting with syncope? So followed by case-based scenarios. So coming to definition, syncope is defined as a transient loss of consciousness and postural tone due to cerebral hypoperfusion. So it is usually very rapid in onset, short duration, and they have a very spontaneous recovery. They usually recover within 5 to 10 seconds or maximum 20 seconds, not more than that, usually most of the population. And 40% of the population have a lifetime incidence of syncope at least once in their lifetime. And syncope accounts to 1 to 3% of ED visits, and nearly 6% of admissions. So there is a recurrence rate of nearly 30% in syncope. So how to differentiate it from seizure? So the points which delineators are which will guide us to more towards the seizure are: whenever the patient has a head turning during the event, the likelihood ratio is nearly 14% and the specificity is 97%. When there is unusual posturing or an absence of pre-syncope, means he did not have any features prior, then the likelihood is 5.6. He has a post-ictal state, means post-event he was in a duration of confusion, then it pushes us most towards seizure. And if the patient has an urinary incontinence, that is also one of the criteria to consider, but we cannot just rely only on that. So distinguishing syncope from seizure is a critical first step in the management of any patient who present to the department with the loss of consciousness. Then, whenever the patient has got a tongue bite, as we have discussed, so it is 100% specific if it is present on the lateral margin of the tongue rather than on the front of the tongue, because once a patient has a syncope, the probability of he falling and sometimes breaking his teeth or injuring his tongue. Uh, Preferably, most likely, the tip of the tongue is most likely rather than the lateral aspect of the tongue. If it's a lateral aspect, then it points out towards seizure. And if the patient doesn't recall the event, then it points out towards seizure. So, what are the possibilities that once a patient comes and it is more likely a syncope? So, clinical features that strongly predict syncope over seizure are event happening when the patient is in prolonged sitting or standing position, means suddenly losing consciousness of or after prolonged sitting position or standing position, guides us that this could be a syncope rather than a seizure. And if the patient has got palpitations before the loss of consciousness, then it could be uh, syncope. Dyspnea, then before the event, syncope. And if there is loss of tone, complete loss of tone, usually that falls in the definition of syncope, where there is a transient loss of consciousness because of reduced cerebral hypopression with loss of tone, that is syncope. And there is something called a 10-20 rule, where some syncopes, they have jerky movements. So if those jerks are less than 10, then it can guide us that it could be a probable syncope rather than a seizure. Seizure jerks usually last 1 to 2 minutes, and there will be more than 20 jerks. Less than 10, definitely, or most likely, not a seizure. Coming to the next question. Is this cardiac syncope? This question is important because patients presenting with cardiac syncope has nearly 30% of mortality in 1 year time. So if there is any question that determines the management of the patient and the long-term prognosis, then this is one thing that we should be worried about. All patients presenting, is this a cardiac syncope or a non-cardiac syncope? So cardiac syncope has got more mortality, so we should be concentrating on that, and we should not be missing it. And what are the suggestive features of cardiac syncope? Any patient more than 60 years, male, who has a past history of any structural heart disease or a past history of ischemic heart disease, or a very low ejection fraction, or syncope precipitated by exertion, or syncope in supine position, or 1 to 2 episodes, abnormal cardiac examination, or sudden loss of, sudden death in the family member who is less than 50 years and who has a family history of inherited heart disease, or the patient having known cardiac uh, illness. So these uh, points will favor us that the syncope could be because of uh, cardiac reason. And things that are non-favorable or unlikely a cardiac event are patients who are younger in age, who do not have any heart disease, occurs only in standing position, and there is a clear prodrome after postural changes, means patient once he's supine or sitting and then suddenly he stood, then he's having giddiness and resulting in fall, then it could be a syncope which is non-cardiac. And if there is a clear prodrome that a patient has got sweating, abnormal sweating, palpitations, and not palpitations, sweating, warmth, feeling of uneasiness, nausea, vomiting, followed by loss of consciousness, then it could be a non-cardiac syncope. Then triggers like pain, dehydration, uh, uh, visibility of blood, or if they are drawn blood, some people it can trigger syncope. So frequent episodes over longer duration with similar pattern could be that. So non-cardiac syncope usually benign, reassurance and avoid triggerance is advised. So what are the red flags? We have discussed most of these things in the previous question, like where age more than 60 and with first episode of syncope, exertional syncope with no prodrome, arrhythmia risk is there, palpitations before the event, history of cardiomyopathy or sudden cardiac death in the family members, patient having a structural heart disease, or patient presenting with chest pain followed by syncope, or uh, patient having a aortic stenosis murmur, or past history of aortic stenosis, or a patient who has got a pacemaker implanted in the past. In all the in these patients particular, we need to interrogate the pacemaker irrespective of the reason of the syncope. It could be a non-cardiac syncope, but still pacemaker interrogation is necessary, because there can be multiple reasons apart from the pacemaker lead break or malfunctioning that can lead to. So this is more lethal, so it needs to be ruled out. So the big three categories in syncope, what are there? Most common, reflex syncope. It accounts nearly 60% of the patients presenting with syncope. It is otherwise called neurogenic syncope. In that, vasovagal syncope is more common. Then comes situational syncope. Situational syncope can be cough syncope, micturition syncope, defecation syncope, deglutition syncope, and carotid sinus hypersensitivity. Carotid side hypersensitivity. Cardiac syncope. So it can be because of arrhythmias, be it tachy or bradyarrhythmias, and channelopathies, Brugada, WPW, or any structural heart disease like aortic stenosis, HCM, MI, tamponade. They have got a high risk of mortality. And the other group constitutes orthostatic hypotension, which could be mostly because of volume depletion, autonomic dysfunction, and drugs. So understanding the mechanism is the key for risk stratification and management. So, if not syncope, what could it be? It could be a seizure. In seizure, if you want to rule out a seizure, then you need to ask questions like, was there any post-ictal confusion? Was there prolonged loss of consciousness? Was there any incontinence? Was there any tongue biting? Was there any involuntary movements? To rule out stroke, you need to look for any focal neurodeficits. And isolated VBA can rarely cause complete LOC. Hypoglycemia is something where patient present with altered mental status and not a true LOC, but very if there is neurohypopenia, then they can have depressed sensorium, but they usually respond to glucose. But hypoglycemia is DD, and it is never a cause of syncope, because syncope is something which resolves spontaneously and self-resolving. Here we are treating with dextrose in case of significant symptomatic hypoglycemia. And the other thing is psychogenic pseudosyncope. So where the patients present with closed eyes, they have a prolonged duration of involuntary movements. They might not have injuries, because seizure patients, if they have a fall or so there is a tendency to injure themselves. So, but these patients, they usually don't see any injuries, and the event lasts differently. So, and there will not be any rise in heart rate and rise in BP, which is expected in a patient who is having active seizure. And there will be like hip writhing movements, pelvic girdle movements, and all. They'll be having abnormal movements, but unlikely seizure, which is not very typical. And the other thing could be intoxication. So the most important tool while evaluating a patient with syncope is history, because with clear history, 40 to 45 to 85% of diagnosis is established. So the critical point in while assessing history is always obtain history from a witness who has seen the patient during the episode, resulting in a fall, or when he was there, because you need to understand about three things during the event: what happened before the event, what happened during the event, and what happened after the event. So posture of the patient during the attack, in fact, before the attack is important. Was he in sitting position, standing position, or lying position? Was he walking, running? What was he doing? What provoked? What did he have or she have any prodromal symptoms are important, or did he have any recent change in medications or recent intake of medications or recent illnesses? And during the event, was the event witnessed, or for how long did it last? Was there any pallor or cyanosis during the event? And was there any tonic-clonic movements? This is important. And after the event, did he sustain any injury because of the fall? How much time did it take for him to for recovery? Was there any confusion or disorientation, and any injuries like tongue bite or muscle soreness? Because muscle soreness can be because of seizure. If there is a sustained contraction for a longer time, their muscles will taught tonicity. Because of tonicity, they'll be having they might complain. They will definitely complain of pain. And post event, if the patient has got confusion for a longer time, then it is more likely that it could be a seizure rather than a syncope. And if the recovery time is also more, then it could be a seizure rather than a syncope. And as we have discussed, if the movements, involuntary movements are less than 10, likely a syncope, more than 20, likely a seizure. So, and if there is a change in color, then likely it could be a seizure, because once they go into sustained contractions because of tonic diaphragmatic contractions, and drooling of saliva and possible aspiration, they might suffer from hypoxia. So all these things need to be questioned. So next comes history taking is done, then physical examination. So what are the single most important things? Means like we need to evaluate during syncope finding. I mean, we need to rule out or rule into a syncope is whether the patient has got any orthostatic hypotension. Orthostatic hypotension is something where the BP, systolic BP falls by more than 20 mm, and the diastolic BP falls by more than 10 mm within 3 minutes from change in position, from lying to standing position. So, and you need to check BP in both the arms and the legs if required to rule out dissections, and the pulse oximetry for hypoxia. Coming to cardiovascular examination, you need to look for any murmurs. Then you need to look for any raised JVP, tamponade, like decreased muffled heart sounds, and in the ECG, any MI or any feature suggestive of a PE, those things need to be looked. And coming to rhythm, we need to look for any irregularity of the rhythm, or if there is any pulse deficit, and carotid bruits. For neurological aspect of physical examination, so need to look for any focal neurodeficits. Patient presenting with seizures, post seizure, some people can have weakness, limb weakness, which could be Tourette palsy. Whether that has led to this, or whether the patient had a stroke or anything and that has led to a seizure, that needs to be evaluated. So if the weakness is not improving for a greater time, then these patients need to be imaged. And we need to rule out posterior circulation stroke. If the patient was complaining of diplopia, dysarthria, already Ds prior to the event, and cranial nerve examination needs to be done. So, following, if in case the fall resulted in trauma resulting in fall, you need to rule out if there is any hematoma or Kunzai requiring imaging, or oral bite, or fractures in other parts of the body. So coming to the different DDs of syncope. So Coming to neurogenic syncope. Neurogenic syncope is usually because of it can be vasovagal or situational or hypersensitivity or Eagle syndrome. So this is reflex mediated and it accounts for nearly 60% of the cases. It is usually because of activation of the afferent receptors, mechanistic receptors present in the ventricles and GI tract, and baroreceptors present in the carotid sinus and aortic arch, which give signal transmission to medulla. And this orchestrates the sympathetic and parasympathetic response, resulting in reduced sympathetic tone, which leads to inadequate vascular resistance and resulting in reduced BP, and excessive activation of the parasympathetic system, resulting in bradycardia, decreased output, resulting in hypotension, bradycardia, and syncope. But these patients, whenever you see, then you need to just make them lie flat and, if possible, elevate their legs so that another 200 to 250 ml of blood, which is usually in the lower limbs, is driven back to the heart. So coming to orthostatic syncope, so postal prodrome, which we mentioned. So like the patients might feel lightheaded after changing from lying position or sitting position to standing position. And postprandial hypotension can occur after having a meal. Medication and like diuretics, alpha blockers, antihypertensives. Whether there is any recent change or recent increase in the dose needs to be evaluated. And in patients like diabetic patients, autonomic neuropathy can result in orthostatic hypotension or resulting in syncope because their body mechanism to cope up with this is very less. And also in volume depleted patients because of dehydration or hemorrhage or fluid losses. So ideally, I mean, we have discussed regarding the fall in BP, but when or at what time are we exactly supposed to measure BPs? Is it immediately, I mean, supine and then make him stand immediately and then check BP, or after 1 minute or after 3 minutes? There has been debates and there have been many studies regarding this. So if the patient is made to stand or head end is elevated to nearly 60 degrees immediately post checking supine BP after making him lying flat for about baseline, to check his baseline BP for after 3 minutes. So 3 minutes, you have a baseline supine BP, then make him stand or make the head end elevated up for about 60 degrees. So there will be a transient drop because of the venous pooling, but this is quickly compensated by the barrow reflex. So it is not very diagnostic and it can give false positive results. So if you check at 1 minute, then it can detect early orthostatic hypotension, which is useful in autonomic dysfunction and volume depletion. But the gold standard, the correct time, ideal time would be somewhere between 3 and 5 minutes. So 3 minutes, because by this time, the baroreceptor mediated compensation should be in a normal person should be complete. And in spite of that, if there is a person fall in BP, that it means that the compensation was inadequate. So hence 3 minutes is the ideal time. Cardiac causes need to be ruled out before any patient is named as or suffering from orthostatic hypotension, because things can coexist. Orthostatic hypotension can be associated with a cardiac event, or it can be because of heart failure also. So looking into cardiac aspect is important. Orthostatic vitals, they do not predict a 30-day serious outcomes. So how to approach a case in case say suppose it's a cardiac syncope, then how to approach this? So whenever a patient comes, then you need to look at these parameters. Easy remembrance, hearts, HERTS. So always look at the heart rate, rhythm, then electrical conduction, axis. Look for the R wave progression, then look for any T wave changes and small low volume voltage changes and any STT changes. So if there is any single, if there is only one test that needs to be done in a patient presenting with syncope, that is ECG. No patient goes out of the department without an ECG who has presented with a syncope. And second most thing is taking history appropriately and ruling out hypoglycemia. So coming to hearts, so it can be because of tachyarrhythmia or bradyarrhythmia, or it can be because of PR prolongation because of AV blocks or short WPW syndrome with the delta wave, RBBP, prolonged QT, left axis left anterofascicular block and left posterior fascicular block, and poor R wave progression or RBBP pattern, cardiomyopathies, uh, low voltage T waves in pericardial effusion, tall T waves in hypertrophies, and also in HCM. Then STT changes like inherit can be inherited in ARVD and Brugada. It can be ischemic in ACS, pulmonary embolism, and dissection. So there was a study where they have compared. So should we treat pre-syncope and syncope the same, or is there any difference between pre-syncope and syncope? Because there is only the only difference between pre-syncope and syncope is the patient lost consciousness in syncope. Here, the patient did not lose consciousness. Otherwise, he suffered from everything. I mean, he felt dizzy, he was about to fall. He took a support and uh, he didn't lose consciousness. So the study showed that there were no differences in primary outcome between the two groups, where the near 18.7% versus 18.2%. So both of them near be it pre-syncope or syncope confers risk to patients similar that the syncope for composite outcome of 30-day mortality is the same. So treat all patients with presenting with pre-syncope and syncope the same. So there should not be any difference in the way the patient is evaluated if he has lost consciousness or if he has not lost consciousness. Same thing. So are there any rules or this stratification criteria that will help us in guiding patients presenting with syncope? Yes, there's something called San Francisco syncope rule, where chest is a mnemonic. Patient present had a history of congestive heart failure, hematocrit less than 30, ECG showing some new onset changes or some STT changes. Patient is short of breath and BP less than 90. So these are high risk individuals and they require detailed evaluation and admission. So this San Francisco syncope rule is highly sensitive, but it is less specific. It can be used as an adjunct to clinical gestalt, and it is never a replacement. Clinical gestalt is the primary thing, and it not only about San Francisco syncope rule. There are a couple of the rules where there has been a study comparing different syncope rules and with clinical gestalt. So all should the same. So clinical with risk stratification is final in deciding whether the patient requires further evaluation or he is fit to be discharged from. And this is something Another rule, Canadian Syncope risk score, where the sensitivity is nearly 99%. So less than 1% is very risk, and more than 20% is very high risk. So the scoring system ranges from -3 to 11, and based on the symptoms and ECG changes, they're stratified and they're scored. So if the patients are falling on a higher score, then there is high risk and they need a further evaluation. And there is another score called Rose rule, where the patient is bradycardic uh, at arrival to the department or at home, or his BNP levels are more than or equal to 300, or rectal examination is showing occult stool for occult blood, or a patient is anemic, or had a chest pain associated with a syncope, or if there is a Q wave in the ECG, or if the saturations are less than 94%. So there are these high risk. So these patients require further evaluation. So diagnostic workup. So question: do all patients require any lab investigations to be done? For every patient presenting with syncope, no. Every patient doesn't. They don't have a set of investigations where we perform for every patient based on the history, clinical findings, ECG changes, focus. You under risk stratification, you decide whether the patient requires any diagnostic workup or not, and then decide what kind of an evaluation he needs. It can be laboratory assessment, or it can be cardiac testing, or it can be imaging to the brain, POCUS, or if there is a strong suspicion of a PE, then we need to work up accordingly. So there is a limited value in low risk patients. So CBC is usually sent when you are suspecting a bleed, or it can be just a blood gas also we can send. And to rule out anemia, any patient presenting, any female clearly presenting in the abdominal plane, vaginal bleeding followed by a syncope, we need to rule out ectopic pregnancy, and beta HCG, urine HCG, ultrasound with abdominal transvaginal to rule out ectopic pregnancy. So if ECG is inconclusive and there is a clear-cut history, or patient has some features of chest pain prior to the event, then proponents needs to be sent and he needs to be evaluated accordingly. And if there is a strong suspicion of a PE, like there is a history of immobilization, or history of OC pills, or history of mazes surgery in the recent past, or if the patient has got a DVT, then and then following that, like the patient had a syncope, then a possibility of a PE is high, then it needs to be ruled out accordingly by doing a D-dimer or a CTPA. And medications and electrolytes. So we need to rule out any dyselectrolemia that has resulted in that, any hypokalemia or hyperkalemia resulting in a syncope because of the medications like diuretics. If there is a strong suspicion, if the patient has got a headache followed by a syncope, or a syncope resulting fall and injuring his head, then a CT has to be done. Or if there is any new onset focal deficit, also imaging needs to be done. So do patients require cardiac workup? Yes. Not all patients, but selective patients who are in high risk, they definitely require cardiac workup. All patients for whom high risk, who fall into the high risk and having abnormal ECG, new murmurs, or who has suspected or known structural heart disease, so echo needs to be done. And patients who have pre-syncope during tachycardia, or a suspected or inducible arrhythmia. So for them, EP studies has to be done where there is any arrhythmia that has resulted in a syncope. So this needs to be ruled out. And even if we are suspecting a neurogenic syncope, with cardiac workup negative, then a table tilt can be done. And if you're suspecting an arrhythmia, a transient arrhythmia, then a Holter monitoring uh, is advisable. Regarding imaging in patients presenting with syncope, so it needs to be considered when secondary causes are suspected, like if there is a patient presenting with headache, neck pain, vomiting, and then followed by a syncope, then SH needs to be ruled out. So you need to do an imaging. It is also indicated if there is a non-trivial head injury occurred as a result of a syncope. So for any CNS lesion to cause syncope directly, it must involve both cerebral hemispheres or the brainstem. So will POCUS help us in identifying anything, or will it give any information? Will it be useful for us? Yes, it is definitely useful because we can rule out abdominal aortic aneurysm with the help of a bedside ultrasound. We can rule out PE by assessing RA-RV dilatation and looking for RV dysfunction and looking for any RV strain. Aortic dissection can be ruled out. We need to screen over the suprasternal area and also all along the aorta. So fast will also help in ruling out free fluid in the abdomen in case if you're suspecting women of childbearing age presenting with dizziness and syncope, and any cases of trauma followed by syncope. There can be a bleed in the abdomen because of which the patient syncopized, or even if it is negative, but the patient, if the abdomen is not soft, if it is not benign, if there is some guarding or rigidity, it can be retroperitoneal hemorrhage also, and it needs to be evaluated. So even then, imaging needs to be done. So coming to disposition, which patients can be sent home, which needs to be admitted. So if it's a clear case of vasovagal syncope where it has occurred because of typical triggers and prodrome is there, there's a trigger, then okay, they're safe to be discharged. If the patient is less than 60, no cardiac illness or no cardiac history, and normal ECG or tropes, troponin done are negative, they're safe to be discharged. And if it's a case of orthostatic hypotension because of a identifiable and reversible cause like a dehydration or a patient standing it for a long time, then he can be sent home. If there are no recurrent or unexplained events, then also it can be those patients also can be discharged. So if the patient falling under a very low risk category also can be discharged, and this requires clear alternative diagnosis because like if did this really cause a syncope, or is there anything else that has caused syncope? If the answer is no, then these patients can be sent home. So whom to admit or whom to observe for some time? So patients having high risk factors in the scoring systems, be it whatever be the scoring system, or any patient having abnormal ECG or having a history of heart disease, coronary artery disease, arrhythmias, they need to be admitted and evaluated. Patient presenting with exertional dyspnea followed by syncope or exertional syncope. So that is more likely a cardiac and needs to be evaluated. And if there is any recurrent unexplained syncope, this patient definitely require admission and evaluation. So which patients of syncope require workup for P? We have discussed. So patients who have a very strong clinical history with a high risk possibility of a PE, they'll require. ECG changes are very suspicious. They require. POCUS is showing dilated right side chambers, RV dysfunction, or a thrombus or evident thrombus in the pulmonary artery, then definitely they'll require admission. Or patient present with a history of suggestion of PE, presenting in the peri-arrest or a cardiac arrest. Post-ROSC, then needs to be first thing that needs to be done is to rule out a PE. So routine PE screening is not recommended. So what are our ED management priorities? So we our basic stuff. Our job is to treat life-threatening causes, identify life-threatening causes like MI, pulmonary embolism, any heart blocks, major hemorrhage, and unstable arrhythmias. So all unstable arrhythmias should undergo synchronized cardioversion. All major hemorrhages resulting in large volume blood loss needs to be transfused with the blood. All case of CHPs, transcutaneous or transvenous spacing, needs to be done at the earliest. And patients presenting with pulmonary embolism, unstable pulmonary embolism, needs to be thrombolized. And all patients presenting with acute MI because of and resulting in syncope, they should undergo PCA. If there is a PCA center, or thrombolysis if it's a non-PCA center and the next center is very, very far. So the risk factors that needs to be addressed during the management of the patient presenting with syncope is to see if he is very dehydrated, or if he is very dehydrated, then volume replenishment is advised. And if he is on any medications like diuretics, alpha blockers, then dose adjustment. If he's having recurrent of symptoms, then dose adjustment is necessary. Or if the patient has got any electrolyte imbalance, be it potassium, magnesium, or calcium, it needs to be corrected. If the patient has got hypoglycemia, this doesn't fall under syncope, but that still glucose needs to be administered accordingly. So all patients who are being discharged should be given instructions. So if it's an elderly patient, fall prevention advice needs to be done, and when to return, and what is further plan. Like say suppose they require any imaging or cardiac workup later on. If they are not willing, initial cardiac workup is negative and the risk is low, but there is recurrent symptoms, then definitely. And if the patient is not willing, then they can come and consult in the next or earliest possible time. Coming to special populations, so elderly people. So elderly people are at higher risk because they have many of them might be having a cardiac etiology versus general population. So general population only 20% risk is there with cardiac etiology, means be it arrhythmias or structural heart disease, versus elderly people. So polypharmacy, so most elderly people will be on multiple drugs which can result in hypotension or in syncope. So multiple comorbidities, injury risk, fractures, head injuries, amnesia, poor recall. So these are all the geriatric challenges that people face. So fall risk needs to be assessed and advised accordingly, and fall prevention is indicated or advised. If the patient has got recurrent symptoms, and dose adjustment of these medications is to be done, along with identifying of cardiac reason if cardiac syncope is suspected. So the management considerations would be we should have a very low threshold for admission in elderly people, because there can be a higher suspicion versus serious cause, and the medication review as discussed. So safety assessment and social support should be given. So history is your best tool. Talk to the patient, talk to the person who has witnessed the event. So exertional syncope is always cardiac until otherwise proven. So, and typical vasovagal prodrome in young is usually benign. Normal ECG with and first presentation of syncope is usually low risk. So LOC for less than 5 seconds usually favors syncope. If it is more than 1 to 2 minutes of the event, jerky movements or whatever, so it favors seizure. So history establishes diagnosis in nearly 45 to 85% of the cases. So history taking is very important. So the common pitfalls here is blaming drugs without temporal relation, because we think that it could be because of antihypertensives, or it could be because of diuretics, or it could be because of alpha blockers in patients with BPH. But things can always be coexistent. So we need to treat both the causes, otherwise it can be recurrent. So unnecessary imaging should be avoided. So mislabeling cardiac syncope as a seizure is a possibility, and we should never discharge high-risk elderly people without any workup. So orthostatic vital monitoring is crucial. So if you have to do two things in any patient presenting with syncope. First thing is ECG. Second thing is checking orthostatic BP. To summarize, so how do we approach a patient with a syncope? Is it a true syncope or not? We need to rule out a seizure, or it can be, is it a stroke or hypoglycemia or intoxication? Or if it's a syncope, is it cardiac syncope or a non-cardiac syncope? And are there any tests that is required? Based on the history, we need to look in. History taking is mandatory. Appropriate history taking is mandatory, in fact. So, and ECG should be done for all cases. Risk stratification will help us in identifying low risk patients and high risk patients. And all high risk patients should be observed or admitted for further evaluation. So immediate treatment of life-threatening causes needs to be taken care, and discharge of low-risk patients needs to be done. Most syncope is benign, but missing cardiac syncope is deadly. Your job is to identify the high-risk group. So coming to case-based scenarios. So have a 20-year-old previously well male with was presented with 30 minutes of palpitations and pre-syncope. So on arrival, he was fine. His symptoms have resolved. So what does the ECG show? As we have just discussed how to go about with the ECG. So we'll be doing it that way, like HEARTS. We'll be doing it. We'll be checking that way. Okay. So here in this case, the heart rate of rhythm is normal. Electrical conduction, there is a short PR. If you see, the PR is short. There is a delta wave also in the precordial leads. You can see it clearly in V3, V4, V5, V2 as well, V6 too. And the axis looks normal axis. And R wave, there is a early R wave progression because of this. And T waves are normal. There are mild anterior ST depressions, and it is discordant with delta wave. So the diagnosis here is WPW syndrome, and this patient will require ablation. EP studies. So next case, 80-year-old female presenting with recurrent syncope while sitting. So there is no chest pain or palpitations. Episodes described as sudden lightheadedness. Her vital state showed heart rates of 48, BP 135 or 75, respiratory rate is 18, and saturations 96 at room air. So ECG taken shows this. When we go about how reading the ECG, it's showing sinus brady with first degree AV block and RBB pattern, and there is a left anterior fascicular block, and there is an RBB pattern, and there is a persistent S wave in V6, which is left anterofascicular block as discussed previously. So it is a trifascicular block, and these patients require permanent pacemaker. Coming to next patient is a 25-year-old male athlete collapsed during exertion. So the event was witnessed and without seizure activity. Reports recent exertional dyspnea. So his vitals on arrival showed a mild tachycardia 1 or 2. Otherwise, there was a doubtful murmur with Valsalva. So his heart rate showed mild tachycardia. Conduction is normal. Access is normal. And there is a tall, if you look at the T waves, tall voltage with LVH pattern, and there is a prominent Q waves. These are dagger-like Q waves. For a patient so young with LVH pattern and hypertension unlikely, so POCUS needs to be done to rule out HCM. POCUS was done and it showed HOCM. So next, the disposal should be cardiac consultation, confirmation to rule out HOCM. Next, 70-year-old female present with active malignancy, presenting with acute shortness of breath. ECG take shortly after arrival. ECG was taken, and patient had a syncopal collapse with hypotension and hypoxia. So heart rates were 115 tachycardia, hypotensive, tachypneic, and hypoxic. So if you look at the volume of T waves, amplitude of T waves, they are very less. So POCUS showed no pericardial effusion, but when we look at low voltage, low amplitude ECG, usually we suspect it could be a pericardial effusion resulting in a low volume. But in this patient, their POCUS was done, it did not show any pericardial effusion, but RV was dilated and there was RV strain, and this patient had a massive pulmonary embolism. So these patients require thrombolysis. 70-year-old patient unwell. After ECG, the patient collapsed. ECG showing RBB pattern and COVID ST elevations. Can clearly see it in B1 and B2. So it's a Brugada syndrome. So this patient needs to be considered for an ICD. Next, 60-year-old male patient presenting with chest pain, then syncope. What do we see? We see ST depressions in V2, V3, V1. V1 to V3, we see ST depressions. So this is a case of post, and there are no ST elevations in inferior leads. There is a minor T inversion which is noted in lead 3, but it is not very specific. So it's a case of posterior wall MI. And this patient cath lab needs to be activated, loading dose of cardiac medications, and shifting to cath lab for PCA. So another case, 60-year-old male patient presenting with syncope associated with hypotension. Initially, this was the ECG rhythm. Then showed this. It's a case of VT. So with pulse, immediate synchronized cardioversion was given for this patient. And then repeat showed this. So what do we have? So we have a RBB pattern. left axis deviation, and diffuse ST. If you see, I'll show you the ECG. And diffuse ST segment depression. So bifascicular block with ischemia pattern. And this was a ECG taken later. Repeat ECG showed these changes with some occasional PVCs here. And the initial RBB, which was present here, got resolved here. And they formed an anterior Q wave with ongoing ST depressions in with the reciprocal ST elevations. Here there is a new onset test AVR elevation and ST depression in lateral leads. So angiodan showed a LAD occlusion. So these are my references regarding the topic. And thank you for your time. So the key takeaways are history matters most in the diagnosis of a syncope. So you need to ask what happened during the event, before the event. Were there any triggers? Were there any prodrome? And what happened during the event? How long did the patient lose consciousness? Was he confused after the event? Were there any jerky movements? Were there any drooling? Was there any tongue bite? Was there any involuntary urination, defecation? And what happened after the event needs to be also evaluated. ECG is mandatory for every patient, and postural vitals are also mandatory for every patient. Rule out cardiac causes of syncope before discharging, and use validated risk stratification scores along with clinical gestalt for final disposal. So safely discharge requires low risk features. Thank you.
Thank you, Dr. Anji. That your presentation was incredibly well structured and easy to follow, especially the case-based scenarios at the end were worth the webinar. Do we have any questions? I suppose not. So the take-home message is that syncope in ER is less about finding the exact diagnosis and more about identifying the risk factors and preventing the bad outcomes. So thank you, Dr. Ranjit, once again for sharing your insights and practical approach. And thank you for the rest who've joined. And we believe that the session will help us feel more confident managing the syncope in our ER practice. Have a great day, and we look forward to seeing you at our next session.
Thank you, Dr. Sayesta.
Thank you.